This time, you are good to go.
Why do I have that? Okay, are we ready to get started? I think so.
There you go.
Thank you.
You're welcome.
Good afternoon, everyone. My name is Taimie Bryant. I'm a member of the law faculty here at UCLA Law, where I'm affiliated with the UCLA Health Law and Policy Program. Today, we will have a presentation by Dr. Charles Grob, also a member of the UCLA community, not at the law school, but as you can see, associated with the School of Medicine. What I would like to do to begin is to acknowledge the assistance of the many people and entities that have helped with this event. Then I would like to briefly introduce Dr. Grob, and so then he will be able to get started. So I'd like to begin with acknowledging various people who have assisted me in this. First, Professor Lindsay Wiley, who's the director of the UCLA Health Law and Policy Program, an enthusiastic supporter of this speaker series on psychedelics. I'd also like to thank the UCLA Multidisciplinary Psychedelics Affinity Group, of which Dr. Grob is a leader and someone with whom I'm able to work in this affinity group. I'd also like to thank the Psychedelics Advocacy Network, which has done a great job of hosting this event so that others will know about it and participate today. There are also individuals who have helped. Millie Lummy, if you could advance the slide. One of the, of the individuals who have helped, there are Millie Lummy, Drivus, my faculty assistant, and Nora Browning, a participant in the class I'm teaching this semester on psychedelics, a UCLA law student who's going to be monitoring the Q&A part of this event. I'd also like to thank the UCLA Law School AV department, which has set me up in this classroom for the purposes of this event, since the equipment in my office is not operable and being fixed as we speak by UCLA Law Information Systems. I would also like to thank UCLA Law Events. They are the core group in helping these events be possible here at UCLA Law. So thank you, Mililani. If we could advance now the slide to the introductory slide about Dr. Grob and his presentation. So as you notice, Mililani, if you could take me back to the slide about the event itself with Dr. Grob's image on it. Thank you. You will see here that Dr. Grob is a professor of psychiatry and behavioral sciences here at UCLA. He is the director of the Division of Child and Adolescent Psychiatry at Harvard UCLA Medical Center. But he is also the co-founder of the UCLA Psychedelics Studies Initiative. So he and other psychiatrists here at UCLA are involved in path-breaking studies, and we will hear about one multi-site study today. So Mililani, if you could show me the slide about, I think you've titled it, previous works. So by way of introduction, I'd like to note that Dr. Grob is a prolific writer, and I'd like to just point out some of these publications that he has done. My hope had been that we would have the full citation for you, but I think here I can just give you a sense of these different studies. If you would like the actual citations, you're free to email me at bryant@law.ucla.edu. My selection of some of these, there are 6 different publications that I wanted to bring to your attention. They show the breadth of Dr. Grob's writing in this area, his scholarship in this area. So I'd like to point out one, Human Psychopharmacology of Huasca, a plant hallucinogen used in ritual context in Brazil. This is a study that Dr. Grob completed some time ago, but which focused on interviewing people who used ayahuasca in ritual contexts and focused on their own experience with it, how they think that the participation in that ritual context and consumption of ayahuasca changed the way they related to themselves, related to their communities. We also see that Dr. Grob was one of the early people, scientists working on the use of psilocybin treatment for anxiety in patients with advanced stage cancer. And this pilot study, I believe, was published in 2010, was looking at a relatively small sample size, also used a moderate dose of psilocybin, I believe it was 2 grams, which is lower than what would be used potentially now to create the kind of experiences that is being found to be most helpful for people suffering from existential angst and demoralization in the as they pass through the advanced stage of cancer. So he has been looking at this type of population, looking at this type of use of psychedelics for quite some time. As I say, I think that first was published in 2010. And a lot of research has been happening since that time with this population and, of course, with others. Could you please advance the slide? So the psychiatric research with hallucinogens, what have we learned, is a look back piece that really talks about some of the historical uses of hallucinogenic substances, and includes a very important part about the history of use by the CIA and others. So we don't have a completely pristine, in terms of ethical models, we don't have a completely pristine history of the use of hallucinogenic substances in this country. And Dr. Grob has been very aware and has participated in a scholarship that brings to light some of these concerns, so that we not repeat any kinds of problems that we can foresee. The piece that was very helpful to me in looking at this part of Dr. Grob's work was a piece that was published in Lancet, Psychedelic Medicine, Safety and Ethical Concerns. So he raises not just physiological kinds of concerns, or not just concerns about the patient's psychological experience with psychedelics, but is also concerned about the field as a whole. So I'll read from this piece briefly. Despite the association between psychedelic use and ego dissolution, grandiosity can loom large with initial psychedelic experiences, leading even conservative individuals to become wildly enthusiastic about the potentials of psychedelics to heal and transform. Although this enthusiasm tends to wane over time, the risks of ego inflation and grandiosity can persist in susceptible personality types. Conversely, people who take psychedelics might aggrandize and fetishize the therapist to administer the drugs to them. There are well-known baseline risks of parental or erotic transference in conventional psychotherapy. We suggest that the risks of problematic interpersonal dynamics are magnified when a patient's therapist not only administers unconditional acceptance and validation, but also expedites access to experiences of transcendence or profound catharsis via a drug. This piece, to me, captures some of Dr. Grob's concerns about conscientious uses, both in clinical trial populations, in studies like the ones that he does, but also in practice out in the world. So again, this last piece, use of the classic hallucinogen psilocybin for treatment of existential distress associated with cancer, is a 2022 publication that shows us where we've gone, and then is a perfect lead-in to Dr. Grob's presentation today, I would think. Those of you who are members of the law part of this audience will be particularly interested in the definitions Dr. Grob provides for such things as spirituality, transcendence, the kinds of things that are very difficult to measure. So with that, Dr. Grob, having given sort of a record of publications going forward, I hope I've positioned your presentation well. I'd like to welcome you to To the law school, we are already UCLA colleagues, so welcome to the law school. Thank you very much.
Right. Well, thank you, Taimie. Happy to speak with you today. I guess I will share my screen. See if this works. Huh. Oh. Oh. Not sure what. Let's try this. Okay. Do you see my slides?
We see your slides.
Oh, good. Okay, let me put it on this. Great. Very good. Okay, so really it's good to talk with you today on a topic that I've found of great interest for a great deal of time. Today I'll talk with you about a study we did in the first decade of the 2000s, and we're in the process of starting a new protocol, which will basically use a similar model, similar population, but looking for a far greater number of subjects to demonstrate this model works in a real world population. So I've been very interested in psychedelics and their implications to psychiatry and medicine, really going back to the to the prior epoch when psychedelics were studied back in the late 60s, early 70s, and I've been able to conduct formal research, survey research in the late 80s, and then in 1993 we conducted our first FDA-approved study. And all of my work has been at Harbor UCLA with the Lundquist Research Institute, previously the LA Biomed Research Institute. I've conducted approved research with psilocybin, which is the active alkaloid in hallucinogenic mushrooms, and also MDMA. And I've done field research in Brazil in 1993 in Manaus in the Brazilian Amazon, looking at an adult population of a syncretic church that used ayahuasca as a psychoactive sacrament. And then in the early 2000s, we were asked to come back by the Brazilian judiciary, who was concerned about minors participating in these religious ayahuasca ceremonies. So we conducted that study as well. But today I'm going to limit my focus for the most part to the model of using a psilocybin treatment model at the end of life to address demoralization and overwhelming existential anxiety. Whoops, that's not good. Oh, good. Okay, so just my obligatory listing of grant funding. Just an overview of what I'll talk about with you today. And one piece to add is we'll also look at the structure for a protocol we're currently moving through the regulatory process with. So I'll get to that as well at the end, as well as kind of future directions and future challenges. So psilocybin is the active alkaloid in hallucinogenic mushrooms. Psilocybe cubensis, the top row, second from the left, is the mushroom species we're most familiar with, but I think it's important to take note of other mushrooms, including particularly psilocybe semialentiata and psilocybe cyanescens, which contain somewhat different alkaloids, and I'll discuss that with you. But also important to note that many, if not most, of the psychedelics we work with in synthetic form were originally discovered in plant form or fungal matter. So with psilocybin, the psilocybe mushrooms, there are almost 200 known species distributed various places around the world. You see, particularly in the U.S. the northwest of the United States, some of the upper Midwest, see through Central America, Northwest South America, and throughout various places in Europe as well. And curiously, the spontaneous distribution of these mushrooms appears to be increasing. They're increasing with following human expansion, and seem to take hold in areas that were previously pristine wilderness that have now been, quote unquote, disturbed to allow for development, building, and the like. As humans populate previously wilderness areas, we're seeing more mushrooms start to arise and found where people congregate. They're also found in association with cattle. They are coprophilic. They grow spontaneously on cow dung, and in this manner, evolutionary, they co-evolved with the human species, but particularly the vehicle seem to have been through cattle disbursement. So a number of cultures around the world, there has been anthropologic and archaeologic evidence of the existence and the value placed on hallucinogenic mushrooms. And here is an example of findings from an archaeological dig in Colombia. These were breastplates placed on the breast of the deceased, and you can see the obvious mushroom caps at the top there, I think indicating to us the degree to which mushrooms were honored or worshipped or revered by ancient civilization. When the Europeans, particularly the Spaniards and also the Portuguese, came to the Americas, particularly South America, Central America, they were very observant of the customs of the native people, and a Spanish friar, Bernardino de Sahagún, commented after observing a all-night mushroom ceremony. He says, and when the effects of the mushrooms had left them, they consulted among themselves and told one another what they had seen in vision. They processed their experience, they shared their experience, and they were looking for signs, for information being conveyed to them, that not even necessarily for personal reasons, but to help the collective, help the community. And they were keen to dissect and analyze the significance of these visions they had during their experience. So these are observations made by Spanish friars. And here you see that the use of hallucinogenic mushrooms as well as other hallucinogenic plants by native people in Central America, South America, were viewed upon with horror by the conquering Christian Spaniards, who associated these hallucinogenic plants with tools of the devil that would mislead and take people down, the evil road, as it were. And decision was made to expunge, to eradicate these native customs, and the laws of the Inquisition were applied towards them, which meant essentially that any native person or even Spanish settler who was caught utilizing these plants or cultivating these plants would be condemned to the harshest punishments of the Inquisition, which generally meant terrible torture and death. Here's another inquisitor, Hernando Ruiz de Alarcón, wrote of what he described as idolatries, and you can see the evil-looking figures holding on to these mushrooms, and they describe these powerful ritual hallucinogens as depriving the user of their senses, causing them to communicate with the devil, depriving them of judgment, and deceiving them. So you can see that these compounds were treated with some horror and and revulsion by the conquering Europeans. And as consequently, the native peoples took their traditional practices, ceremonies, and knowledge of plant use deeply underground, to the point where Europeans were not even aware after some time that these ceremonies were still extant, were still active. So the use of these compounds for sacramental use date back many millennia. And here's some of the oldest evidence. This is a drawing made by the artist Kathleen Harrison, who, this is based on a cave painting in the Taimie Plain in southeastern Algeria. And you can see the cave painting depicts a shamanic figure with mushrooms coming out of his or her torso and limbs. And you can see the mask in the shape of a beehive. And the significance of the beehive mask was that in the ancient world, and certainly in the prehistoric world, there was no refrigeration, but one way to preserve plant matter and fungal matter was to use honey. So that's the significance of the beehive mask. And anthropological evidence that these compounds were used for religious and medicinal uses going back thousands of years, used by widely diverse cultures around the world, and had a profound, albeit not well appreciated, influence on the evolution of religion, philosophy, and art. So fast forward to the modern era. By the mid-century, the mid-20th century, it was believed that hallucinogenic mushrooms simply did not exist. They were thought to be either myth, that there were hallucinogenic mushrooms, or they thought to be confused with peyote, which was known and appreciated as having visionary properties. But in the early 50s, an amateur mycologist named R. Gordon Wasson, whose day job was being a vice president of JP Morgan Trust on Wall Street, but with his wife, Valentina, a Russian-born wife who was fascinated with mushrooms herself, they were exploring mushroom use and mushroom mythology around the world. They received a letter from a friend of theirs, the British literary figure Robert Graves, saying that he had heard rumors of an extant mushroom cult in the highlands of north central Mexico, in Oaxaca. So the Wassons organized an expedition, went out to Oaxaca, to a village, and where they made the acquaintance of an indigenous curandera named Maria Sabina, who invited them to join a mushroom healing ceremony of Velada. And although Wasson had promised he would keep this information under wraps and not reveal it to the world, he did just that. He revealed it to the world through the vehicle of Life magazine. He evidently was close friends with Henry Luce, the publisher of Life, and Luce prevailed on him to write up the account of his experiences. And also this little fella here is not a mushroom elf or gnome. He's a Broadway actor named Burt Lahr, who has nothing to do with the story, but his picture was on the cover. You can see there the great adventures, the discovery of mushrooms that cause strange visions, and they can be very, very strange. So here's a picture of Wasson in his senior years with a mushroom stone from Central America, and here he is in the pages of Life magazine with the curandera Maria Sabina as she hands him mushrooms for him to ingest during a velada, a healing ceremony for a local person who was ailing. And Wasson had an extraordinary experience. He had a knock your socks off, profound visionary experience, which you can see how he described it. And some individuals under the influence of these powerful plant hallucinogens or synthetic hallucinogens will have this level of visionary experience, ecstatic states of mind. But we should keep in mind that not everyone has such an exalted experience, and some have a very scary, a very, very frightening and even disorienting experience. And here's a picture from a British magazine in the 1870s, accompanying an article that discussed inadvertent mushroom poisoning in the English countryside by individuals seeking culinary mushrooms to cook with, mistook psilocybin mushrooms and prepared their omelets with psilocybin mushrooms and were in for a shocking surprise. And given their inattention to set and setting, given to their not being aware of what they were about to take and not optimizing conditions and not being prepared and not really knowing the first thing about such compounds, many of these mushroom hunters in the English countryside had a very, very frightening experience. So something to keep in mind, that although these compounds can exert very, very profound ecstatic states, they can also induce very frightening, anxiety-ridden, and even psychotic states. So let's talk briefly about the chemistry. It's important to point out that psilocybin, along with other classic hallucinogens, has a very, very close similarity from a chemical structure perspective to the major central nervous system neurotransmitter serotonin. Serotonin is 5-hydroxytryptamine, and psilocybin is 4-phosphoryloxy and N-dimethyltryptamine. You can see they both contain an indole nucleus. And psilocybin is the compound found primarily in the compound. Psilocin is the secondary compound and also a metabolite of psilocybin. But its half-life is very quick, and the significant psychoactive effects are presumed to be secondary to the psilocybin. So these are tryptamines. They have share an indole nucleus. They resemble, from a chemical structure perspective, serotonin. And so in a sense, there are these receptors, serotonin receptors, that are primed, that had evolved to be receptive to these very powerful hallucinogenic alkaloids. So how that came about and why during evolution is anybody's guess, but it's quite remarkable the sensitivity these receptors have to the ingestion of hallucinogens. In fact, LSD, another classic hallucinogen, is active on a microgram level, one of the most biologically active compounds known to man. So it's interesting phenomena. And also relatively low toxicity, although as time has gone on, I've become more aware that one should take the term low toxicity with a grain of salt. Certainly, psychologically, it can induce a toxic level experience, a very frightening experience, which can sustain for a period of time. Physiologically, always thought to be of little concern. However, recently there's evidence compiling that effects on cardiac valves, which have serotonin subreceptors 5-HT2B, may be responsible to an enhanced risk for cardiac arrhythmias. And this is an area that needs to be studied further by investigators. It's kind of been a neglected area, but range of physiological effects, particularly cardiovascular effects, we need more data. I've got some data, but for the most part, investigators have not really looked at this. We can discuss why that's the case later. So again, psilocybin is chemically, the name is 4-phosphoryloxy and N-dimethyltryptamine, a substituted indole alkamin and tryptamine. Active psychological effects, psychoactive effects, primarily at receptors that are receptive toward the 5-HT2A and 2C receptors. But as I mentioned, the 5-HT2B, which rests pretty densely on cardiac valves, there may be some concern there for cardiac arrhythmias, particularly with a frequent use pattern like microdosing. Even though it's an infinitesimally low dose, the rapidity of dosing daily for some days over many weeks or even months can potentially create a cardiac risk. So in our study, we used a medium dose level of psilocybin, and we were able to facilitate a well-controlled altered state of consciousness that lasted approximately 4 to 6 hours. This looks at the intensity of psilocybin compared to a couple of synthetic hallucinogens, and you can see that the intensity peaks about an hour and a half to 2 hours, and then starts to come down, and by the 4 or 5 hour point, it's down to almost baseline. 6 hour, it has hit baseline. And you can see the difference, let's say with LSD, which is a much longer lasting drug, making it more difficult to use in treatment. And it really has not, while LSD was the primary psychedelic of choice in research in the 60s, psilocybin is the compound that we've used in the 21st century. And I'll get into the reasons why. So here you have plasma concentrations, and you look at like the, around 6 hours, 7 hours, plasma concentrations are down, approaching baseline. And here you see excretion in the urine of metabolites that very, very low by 6 to 12 hours and pretty much out of your system by 12 to 24 hours after ingestion. And like when law enforcement wants to do analyses to detect particular drugs, they're pretty much out of luck if they look beyond 12 to 24 hours with this compound, because it will simply be undetectable. Whereas in the acute phase, that's another issue. They just have to use the right chemical assay. So this is interesting. This looks at the percent of 3 different alkaloids that can exist in mushrooms. Psilocybin, which is a primary alkaloid associated, which we'll talk about primarily today, and which in laboratory synthesized form we use in our study, and my colleagues around the country and Canada and Europe are also using psilocybin. But there's also psilocin, which I mentioned is a metabolite, but also exists in the mushroom, does have a short half-life. And then there's baeocystin, an entirely different alkaloid, which has not received very much study at all in humans. And you can see a couple of these species, particularly Psilocybe azurescens and Psilocybe semilanceata, have relatively high percentage of baeocystin compared to Psilocybe cubensis, which has a very low level of this baeocystin. So that's an area that's ripe for future research. What is the role of baeocystin in the mushrooms? What are its effects when administered on its own? So there's a lot. If this field continues to flourish, there's a lot of questions to answer. So the range of subjective effects of psilocybin, the stimulation of affect, can induce very powerful feeling states, enhances insight and capacity for introspection, very similar to a dream or a hypnagogic state. It's like a waking dream where one is aware of that they're under the influence of a powerful compound, and yet with eyes closed they have visions, and these are visions of thematic content. They tell you a story, much like a dream will tell you a story. There are unusual perceptual changes, particularly synesthesias, where the perceptual phenomena are mixed up, where you may visualize sound or smell color, a very, very unusual perceptual experience, which is kind of a noted factor in these compounds. Also with the subjective range of effects, the peak experience, psychedelic peak experience, akin to the mystical experience, transcendent experience. It conveys a sense of unity or oneness, a transcendence of time and space, very, very positive mood, sense of awe and reverence, powerful states, meaning, psychological meaning, really infusing one's with powerful, that objects and thoughts and experiences have profound meaning, also endows powerful philosophical insight and ineffability. It's very hard sometimes to put these experiences into words. A paradoxicality, what you perceive may not actually be what is the case. And transiency, it's, while you're in the state, it's as if it's going on forever, but once it's done, it's as if it passed in a flash of an eye. So that's the psilocybin experience. Two very important figures in the history of, or early figures in the history of psychedelics. Albert Hofmann, the noted Swiss natural products chemist, worked for Sandoz Laboratory in Basel, is renowned for discovering LSD in 1943, but not well appreciated is that he was the one who first isolated psilocybin from mushroom samples. When Wasson returned from Mexico, he brought with him a number of samples of the mushroom. He sent them out to the leading medicinal chemists around the world. None of them could crack the code. None of them could identify the active alkaloid until Hofmann took a shot at it, and he was the one who first isolated psilocybin. So Hofmann, who lived to 102, I went to his 100th birthday celebration, and he gave a talk to 2,000 people in Basel. It was remarkable. A 100-year-old man with on his feet, speaking extemporaneously and very, very clearly for an hour. It was quite a remarkable individual. I had the opportunity to meet him on a number of other occasions and have published some interviews I conducted with him. And really one of the great, although unrecognized figures of the 20th century. And then there was Aldous Huxley, the very famous British literary figure. What many people don't realize is that in the early 50s, he became aware of this new drug that had been discovered in Switzerland, as well as related hallucinogens. Excuse me. And he arranged with an English-Canadian psychiatrist researcher named Humphrey Osmond to have a mescaline experience in 1954 when the APA, the American Psychiatric Association, met in Los Angeles. And he had a very profound experience. He wrote about it in Doors to Perception and Heaven and Hell, which were widely disseminated. What people don't realize is that his very last book, called Island, was really devoted to his understanding of the potential value that psychedelics may have to the world. He also felt that psychedelics may have some role to play in helping to facilitate the transition from life to death. And Huxley not only talked a good talk, he actually walked the walk. He arranged on his deathbed to be administered 100 micrograms of an injection of 100 micrograms of LSD. He arranged this with his wife Laura, who was a friend of mine in the 90s and early 2000s. I got to know her well. I heard her stories many times, and the doctor, the attendant doctor. And when Huxley gave a signal that he was ready, they injected him, and he had what one would assume to be a very powerful experience, although there was no trip report. He passed away. He was very close to death at that point. Curiously, after he passed, Laura, his wife, went to inform the relatives and friends who were holding vigil in the home, and she couldn't find anyone in the house. So she walked around until she found everyone clustered in the only room that had a TV. And they're all watching something on TV, and she was furious that they were not, that this was disrespectful, that Aldous had just passed, and they were, just lying around watching TV. But before she reprimanded them, she took a closer look at what they were watching. They were watching the first reports out of Dallas that John Kennedy had been assassinated. So on the precise moment in time that Huxley, one of the great early figures of psychedelics, passed away. Almost at that precise point in time, our president, John F. Kennedy, was assassinated in Dallas. So just a little piece of historical curiosity. So Lester Grinspoon, a Harvard professor, did a very important book published in 1980 or 79 called Psychedelics Reconsidered, and he reviewed over 1,000 clinical papers that detailed the experiences of some 40,000 some odd patients who were treated with psychedelics or who were in research studies where psychedelics were used. And these were some of the treatment applications. Some of the more important ones with alcoholism. I found the value of a psychedelic treatment model to be most significant when we're looking at psychiatric conditions that do not respond well to conventional treatments. So first and foremost, what jumps out at you is alcoholism. We still do a very poor job treating alcoholics. If we refer to 12-step groups, and if it's a good fit, it can be tremendously helpful, but it's not the right fit for everyone, and we don't have much else in the way of treatment options. But some of the early work, starting with Humphrey Osmond in Canada in the 50s and through the 60s with Stan Grof at University of Maryland, they found very, very strong treatment effect using a psychedelic treatment model with severe alcohol abusers. And a recent study at NYU led by Michael Bogenschutz, utilizing a psilocybin model, has corroborated these early results. Also, there's other difficult to treat conditions, as you can see on the slide. And I'll just shoot down to there's autism. We did a study back about 6 or 7 years ago using an MDMA treatment model, 3,4-methylendoxymethamphetamine, a phenethylamine hallucinogen, to treat high-functioning young adults on the autism spectrum who had incapacitating social anxiety, targeting the social anxiety, not the autism, but these were autistic cases. These were simply more difficult to treat cases. And we got a very, very good treatment effect with our study. But also, for the purpose of this talk, I'll focus a little bit on the existential anxiety and terminal cancer. This is an area that I think when I first heard and read of these results, must have been around 1971, 72. I was just blown away by how really the implications of some of the early work utilizing a psychedelic treatment model with people approaching the end of life. Let's talk about that. Hallucinogens for advanced stage cancer anxiety. So as we all know, final months of life are often very, very challenging. It can be associated with terrible high levels of physical and emotional distress and suffering. As the individual approaches death, it's not uncommon for significant depression, anxiety, and psychological isolation to occur. Our conventional treatments, including SSRI antidepressants, are often lacking in terms of facilitating or alleviating these distressing symptoms. Individuals feel a tremendous degree of helplessness, hopelessness, and it extends to attendant family and even medical personnel. It can be overwhelming existential crisis for all concerned. And although we do need to, acknowledge that the field of medicine, oncology in particular, has made great advancements in the last half century, increasing the duration of life, but still addressing the quality of life there have been improvements through the advent of the hospice movement, palliative care specialties, but still it's quality of life. I think there's a general consensus that, at least with many individuals, more could be done. Individuals often kind of lose their sense of meaning, their purpose when in this existential crisis. But here we may have a treatment model that can address this existential dilemma people find themselves in. So the first physician to start examining the potential use of a psychedelic model with individuals with advanced cancer was a Chicago internist and psychiatrist named Eric Cast, who was a pain specialist. And he heard about this new experimental drug in Switzerland. He wrote away and simply explained that he was a doctor with a specialty of pain control and would like to get some samples to check it out in his patients. And they just sent him a bottle of LSD pills, which he got in the mail. He had no idea how to utilize it, no idea how to prepare subjects or how to prepare the treatment environment. So there was initially at least no preparation. He basically said to his patients, he said, here's a new medicine, take it later today, and when I come by my rounds tomorrow, I want you to tell me what it did. Well, he quickly learned that he needed to address set and setting, prepare subjects, and prepare the room where they were going to take it in. And once that was accomplished, he did find very powerful analgesia comparable to conventional opioids. But unlike conventional opioids, whose analgesic effects wear off as the drug wears off, the patients he had treated with LSD reported a reduction of pain that could last for many weeks. And he explained this as part of his theory of attenuation of anticipation, that people with chronic pain are not only addressing the pain in the moment that is overwhelming them, they're also anticipating the pain in the minutes, hours, days that this pain would most surely come. So there was anticipatory pain as well. He felt this drug treatment could cut that connection between anticipation and actual pain in the moment. And he felt, again, he found very powerful analgesic effects. He also noted improvement of mood, improved sleep, and lessened fear of death, and the occurrence of happy oceanic feelings lasting up to almost 2 weeks following treatment. Walter Pahnke, a Harvard-trained psychiatrist, he also had a doctorate in divinity. He recruited 17 patients with advanced cancer, treated them with one LSD experience, found that 2/3 reported improvement, half of those dramatically, half of those moderately. And curiously, he also found that the most dramatic effects came within the context of a powerful transcendent or transpersonal, spiritual or mystical experience, and associated with those individuals who had the mystical experience were most likely to have a diminution in fear, anxiety, worry, depression, needed less pain meds, increased serenity, peace, calmness, and decreased fear of death. Pahnke's colleague at University of Maryland, Stanislav Grof, one of the most distinguished investigators in this area, going back to the early 50s when he was in Prague, Czechoslovakia, and who is still around, and he still gives talks online. He's in his mid-90s by now, a remarkable individual and really a true visionary whose works are highly recommended to read. He treated 60 terminal cancer patients, and again, he found upwards of 70% improved, 30% dramatically, 40% moderately. So and again, like his colleague Pahnke, he found that the most powerful outcomes were with those individuals who had deep spiritual, religious, or mystical experiences. So, so in our study, which we conducted, this part of the study we did in the 90s, we got approved. This was the first approved study of this sort in several decades. We were approved to treat 12 subjects, all with metastatic cancer with a very grim prognosis. I think in this study it was expectation of less than 6 months. All had significant reactive anxiety, and these were all adults. We were very careful excluding individuals with who might have increased vulnerability. We were concerned about inducing seizures in individuals with epilepsy or primary brain tumors or cancer metastasized to the brain. So we excluded all patients like that. I think in the future moving forward, we're going to be looking at a more pragmatic kind of population that one is likely to see out in the world and there will be, I think, some efforts to be more inclusive. But for this, the first study of its kind in decades, we were very, very careful. We also screened out cardiovascular illness. I think we're going to be opening those parameter up as well. We screened out treated people on antihypertensive treatment who still had high blood pressure parameters. And you can see also liver and kidney problems, diabetes also, as well as a history of a psychotic illness, including a bipolar illness in the individual or even a first-degree family member. So we were very careful with who we let into the study. We provided a preparatory psychotherapy, several sessions, myself and my co-investigator. This was a double-blind, placebo-controlled methodology. Neither the subject nor myself nor my co-PI knew what they were getting, but they would come in for 2 sessions spaced a month apart, and they would be randomized into getting either placebo first or psilocybin first, and in identical looking capsules. And then 4 weeks later, whatever condition they did not get the first time, they would get the second time. So everybody got a psilocybin experience, everybody got an active placebo experience, but the order was randomized and it was all blinded. So I didn't know, apart from just, having kind of a hunch or intuiting who might be on what. So we took your normal, drab, unattractive hospital room, and fortunately it was a single room. So no, because a double room with someone else, it's a non-starter. But fortunately, my co-investigator was very good at fixing the room up, and we hung drapes and kind of cocooned the subject in there, brought in flowers, had them bring in pictures, even wall hangings that would be, kind of help it to look like anything but a hospital room. We also had this was formerly a sleep research room, so we had 2 heavy doors, which when closed would knock out all the ambient sound from the hospital hallway. So it kind of worked out pretty well. We had a number of survey instruments, getting baseline measures, looking at mood inventories, anxiety inventories, just general psychiatric rating scales, pain inventories, quality of life inventories. You can see there was, depending on the inventory, we did various degrees of follow-up, various intervals, up to 6 months out. So we stayed in touch with everyone for 6 months, collecting data. Now, I often used to get asked, why did we choose psilocybin, not LSD? Because LSD was almost always the research psychedelic of choice. And the reason why we chose psilocybin is gentler and less intense, easier to guide someone. It's a shorter duration, 4 to 6 hours, compared to LSD's 8 to 12. 4 to 6 hours just sitting with someone is a long, long time. How those guys back in the 60s did 12 hours, I don't know. I think they had to have shifts of investigators come in. But I think there's advantages to having just one team working with the subject. Also, psilocybin has a stronger visual or visionary component and induces, very positive mood states, significantly associated with fewer panic reactions, less in the way of anxiety, less likelihood of paranoia, but also very, very important, there had been less negative publicity about psilocybin. Most people wouldn't even know what psilocybin was, whereas LSD, especially back when we started this, 20 some odd years ago, people knew what LSD was, and by and large, people generally had a negative impression of LSD, so we didn't have to deal with all the negative publicity about LSD over the decades of the 60s and 70s, even the 80s, and it was less likely to be problematic or impede subject recruitment. So here's something important, and I wanted to spend a little time here because it's relevant for today's world. We had to get through some regulatory hurdles, and it actually worked out very well, going through FDA, DEA, as opposed to warnings I'd received from colleagues who said, oh, they're going to be very rough on you. They were very collegial, everyone had a critique. All the committees had a critique. We had to make adjustments to the protocol, but at the end of the day, we got the approval, and the critiques actually, I think, probably made a stronger protocol. We also had to go through a state committee, in the Justice Department of California, the only such committee in the country, state-run committee. They basically have to review all Schedule 1, Schedule 2 research protocols. Now, the problem that I'll point out, that we've never had a problem in the past. We've gotten fair reviews. They've critiqued us. We responded to the critiques. They approved us. But the research advisory panel, and we have a protocol that's been there since last spring. They met in June and reviewed the protocol, had some critiques. We addressed the critiques. We resubmitted, and it was slated to be reevaluated in August. But over the summer, the Justice Department basically shut down the activity of the research advisory panel. And our protocol, as well as 20 or 30 other protocols from around the state of California, have languished there, not reviewed, because nothing to do with the old taboo about doing any work with psychedelics. It simply has to do with a controversy as to whether or not committee meetings in the Justice Department in California can continue to be conducted behind closed doors, or if they should be conducted in public, and be more transparent. I'm neutral. I don't care which setting our protocol gets reviewed. We're open, we're transparent, we're not secretive about what we do. We'll post our protocol eventually online, but what's intolerable is that we're now past 6 months and it has not been re-reviewed. It's supposed to be re-reviewed in the next meeting in April, but that's still the way things have been going. This hiatus in reviews may keep going. There was actually a big article, front page article in the LA Times about this a few weeks ago. So it's a big issue that's impeding all new research of psychedelics in California, and so this is a problem. And so I just thought I'd throw that out there. Maybe someone has a connection to the governor or someone. So these are our subjects in the study we did. Curiously, of our 12 subjects, 11 were women, only one was a male. They range in age from the mid-30s to the late 50s. And you could see the duration of their cancer and their metastatic spread. There were 4 subjects with metastatic breast cancer, 3 with colon and colorectal cancer, 2 with ovarian cancer, and 1 each with multiple myeloma, salivary gland cancer, peritoneal cancer, and 1 other, multiple myeloma, salivary gland, and peritoneal. Yeah, that fits. So, and everyone expired within 2 years. The goal of the treatment was not to extend duration of life, it was to improve quality of life. But some people did appear to hang on a bit longer than their prognosis would have indicated. So physiologically, this is a moderate dose. People tolerated very well, minimal change in heart rate, minimal blood pressure changes, systolic and diastolic. We looked at some cardiac measures, and we found a significant degree of the arrhythmias we're looking for, but it was kind of equally matched between placebo and active drugs. So this needs more. We had Holter monitors in everyone throughout the duration of the 6-hour treatment. And actually they were admitted the night before when we put the Holter monitor on then, so we had a good baseline as well. There needs to be more work done evaluating cardiovascular reactivity. That's important. This is a phenomenologic scale of subjective effects. OB is oceanic boundlessness, VR, visual restructuring. Those came out the highest differences between psilocybin versus placebo. And you can see just what these refer to: more derealization, depersonalization, altered sense of time, positive mood, as well as facilitated imaginative structures or functions, synesthesias and the like. In interest of time, move on. Minimal effect 2 weeks out after administration of psilocybin on mood. But when you look at 6 months out after each psilocybin session, now some received psilocybin first, some received it second, but this would be the 6 month after psilocybin, you found a significant and sustained improvement in mood, which reached significant proportions at the 6 month point. Here for anxiety, state trait anxiety inventory. State anxiety is how anxious do you feel in the moment, and either 2 weeks out head to head with the placebo or kind of on its own 6 months out. No effects on state anxiety. But if you look at trait anxiety, which is how anxious do you consider yourself over the last couple of weeks, you see a significant drop in trait anxiety in the 6 month measure that quickly reached significant proportions and sustained over that 6 month period of time. And the sustainability of the treatment effects, in my mind, is one of the more remarkable phenomena associated with psychedelics. We publish in the Archives of General Psychiatry, since renamed JAMA Psychiatry, the #1 impact journal in the field. So we were delighted we got it published there because it meant our colleagues thought this was an important area. Our colleagues at NYU kind of followed up to replicate our study. They got permission to use a higher dose. They found even more significant findings, improvement in mood and diminution of anxiety. And also our colleagues at Hopkins, similarly, using a higher dose, found even more significant degree of effects on depression and anxiety. Now, our current study is pragmatic trial of psilocybin treatment in the palliative care setting. It's a multi-site study. We've got 5 approved sites, and we're ready to roll. All we need is the final regulatory approval from the state of California. The hub, the administrative hub will be at Harbor UCLA or the Lundquist Institute. The sites include Harbor UCLA, UCLA Medical School, UCSF, Marin County Comprehensive Cancer Center, and another cancer center outside of Washington, D.C. And we're making this a more pragmatic study, looking at a real-world population. As you're probably well aware, psychedelics has, just in the past few years, kind of interest has exploded. People are very interested in utilizing psychedelic treatments. And so we're looking at its application with this population that we have prior data, but the goal is to treat between 100 and 120 subjects. Now, a fact of life is that the one thing we all have in common from the point of birth is that inevitably, ultimately, everybody dies. And sadly, many people experience significant degrees of existential suffering. Conventional treatments, antidepressants, and psychotherapy, for one degree or another, are problematic, or they're often ineffectual. They can be very expensive, or psychotherapy can. They can be valuable in some cases, particularly when, psycho-oncologists are involved, but often not up to the task. Psychedelic therapy, looking at the data out of the 60s, as well as our data and the Hopkins data and the NYU data, I think is encouraging that we may have a treatment model which is going to be more effective. And also we know that there's a high level of demoralization. That's our primary target symptom, is demoralization. With these ameliorating demoralization, ameliorating the existential crisis. This is our team: Tony Bossis at NYU, Alicia Danforth, both at Harbor Lundquist, as well as UCSF, and Brian Anderson, very talented young investigator at UC San Francisco, has been really pivotal in organizing this protocol. Here are just some other centers from around the country that have done or plan to do preliminary work. A good study just came out of Dana-Farber in the Harvard system in Boston, and other settings as well. these are the studies that have been done. Our study at Harbor UCLA, the NYU study, Hopkins study. UCSF did a similar study, but with HIV survivors who had severe, chronic, intractable depression, and really a lot pathologic degrees of survivor guilt. Brian Anderson and Alicia Danforth did a psilocybin treatment model with that population with good results. So so just looking at some of the issues, the compelling issues, what are the actual risks? We do need to do a closer look at individuals with severe medical incapacity and understand the degrees to which it is different. For instance, we would screen out severe cardiac arrhythmias. We're now going to include more, and we'll have necessary precautions taken for rapid intervention. But we need a better understanding of how out in the real world people with different medical illnesses are going to react to this treatment. We don't really have that information yet, but given that it's becoming legal in various states, Oregon and Colorado have approved at the ballot a treatment. That treatment is permissible with psychedelics under certain conditions. We need to really start learning more. We need to have more diverse populations. It has always been treatment patients have tended to be Caucasian, more in the affluent end of the socioeconomic spectrum. We need just more diverse inclusion from across various spectrums. We need to get a better understanding of dosing. We have some flexibility in dosing. The standing dose will be 25 milligrams, but we could take it a little higher or a little older depending on factors in the treatment. We're standardizing and manualizing the treatment process, and we're going to be training a new generation of facilitators. We're using an apprentice model. So this is a multi-center, multi-sites, hoping to treat 100 to 120 patients, pragmatic real-world patients, real-world providers. We're collaborating with palliative care providers and oncologists. We're using a moderate high dose, but we can tailor that dose depending on the situation. Our active control is low dose, orally administered ketamine. We expect the ketamine to induce a therapeutic effect, but for it to subside after about a week. And so we're postulating that the psilocybin treated individuals will have a sustained improved status of lowered anxiety, improved mood, lessened demoralization, and improved overall sense of meaning and purpose. We're using a meaning and purpose manualized therapy developed in Australia by David Kassane, a psychologist there, and the outcomes looking primarily at demoralization, but also depression, anxiety, quality of life, pain. So this is the model. Basically, so people will get, it's blinded, they'll be randomized to either psilocybin or ketamine. A placebo condition is attached to each of those, but they get either psilocybin or ketamine on the day of treatment. There's preparatory, there's a screening and then preparatory therapy. And then following the treatment, there are a couple of integrative sessions to help people pull it all together. And we follow up for 5 weeks, and then we break the blind. And for any subject who received the active placebo ketamine, they will be able to get an open label psilocybin session. We felt for ethical reasons, we wanted to be able to provide the experience people were hoping to get for everyone, given their time is very limited. So we're using a core group of experienced facilitators, partnering them up with quote unquote apprentices from palliative care and oncology settings who really have so much more expertise than the mental health facilitators, because they see nothing but people approaching the end of life, where we're involved in various other matters. But for the sake of this study, we're calling those who have experience administering psychedelics as the experienced facilitators, and the apprentices are those for whom the psychedelic model is new and novel. So we have a system where they will kind of sit with us for a certain number of sessions, and then they would become the experienced facilitators. So we do quantitative and, importantly, qualitative evaluations. We have a colleague from University of Notre Dame who will handle the qualitative measures, and we found FDA, other regulatory agencies to be very helpful, positive, except for this recent problematic situation where it's not the fault of the committee. The committee's basically been instructed to stand down until this decision is made by the state as to whether the meetings should be open or closed. It just seems, it's just very frustrating that for over 6 months we've been holding our breaths on hold, still waiting. So, plan to start enrollment this year, and run the study this year and next year and get this published in the near future. Sidney Cohen, one of the early pioneer researchers in the 60s at UCLA, wrote on this topic in the mid-60s. Death must become a more human experience to preserve the dignity of death and prevent the living from abandoning or distancing themselves from the dying. It's one of the great dilemmas of modern medicine, and I think that still holds today. And I don't know how much time, well, maybe a couple minutes. What are our future challenges? Here we have, kind of ancient mushroom stones from many centuries ago, from pre-conquest. And they're supposed to, and native lore would tell you that these mushroom stones imbue the knowledge and the wisdom of the mushrooms. So I figure they're looking at it at us, and basically the message is, you guys better do this right, because you may not get another chance. Things fell apart in the 60s for a variety of reasons, and here we're gifted with another opportunity to test this treatment model out. So use it wisely, use it properly, and have the right intentions about it. So implement the lessons of the past. This means we need to learn not only from the pioneer researchers of the 50s and 60s, but also the true experts who were the indigenous people, the native peoples from around the world, who had intimate knowledge of the range of effects of all the plant life that grew in their geographic region. They knew which plants were nutritious, which plants are toxic and to be avoided, and which plants were visionary and to be used only on very, very special, important occasions for the collective, more so than the individual. It's important that if we're going to succeed, we need to optimize our safety standards, and we need to optimize our ethical standards. This is key to this field moving forward, and I'd like to see more attention paid to these matters. We need to understand and prioritize the implications to public health. One reason why things rapidly unraveled in the 60s was that psychedelics kind of got out of the lab, got out of the treatment setting, and found its way to some of the youngest and least prepared members of society. And there was a perception, to some degree true, of a public mental health crisis with the wide, indiscriminate, uncontrolled use of psychedelics, particularly by the late 60s, early 70s. Implications of microdosing. I think there's some concerns for cardiac complications that need to be addressed. And also, does microdosing work? There's a lot of buzz in the press within the so-called psychedelic community, but there has yet to be a well-designed study that has demonstrated efficacy, much less safety. University of Chicago yielded equivocal results, and there's a new study, I believe it's the University of Leiden in Netherlands, which is looking at this. We need greater diversity, both in our subject population. We need more. We just need more diverse representation. We need more, people from minority groups or different ethnicities to be involved in this field. It should not be the preserve of affluent Caucasians alone. And we need, patients and facilitators who represent different, ethnic groups and cultural traditions. navigating regulatory obstacles. We found our the regulatory officials to be very collegial, and we've been able to work with them. And my working with them goes back some 30 years until we've had this recent hiccup, which I hope and expect will be resolved pretty soon. And funding options, and there's a whole issue here of big pharma getting interested, or people from big pharma who see this as an opportunity to extract tremendous profit. And there's some ethical issues about, I think, a number of different levels, fixating on profit, extraction. I think honestly at the expense of establishing and maintaining strong safety parameters. So, and also expanded access. More and more people are hearing about this. More and more people are using. There needs to be good public education. Oregon and Colorado have de facto decriminalized psychedelics. Other cities around the country, Denver, Santa Cruz, Oakland, Washington, D.C., Detroit, it's happening pretty quickly. So expanded access. But to the people who are hearing about this, do they really know what this is all about? Do they understand, what are the limitations? What subjects or potential participants in the experience should be ruled out because they carry certain risks? Do they understand how to optimally structure these experiences by optimizing set and setting? And so that's my talk. I think I maybe went a little over. So I don't see anybody out there. I don't know if I'm speaking into a void or there are people in the beyond. So Taimie, maybe you can let me know.
Well, I'm certainly here. And
okay, you're there. Okay, good. Somebody.
Of your presentation. Could you please, well, actually, you could keep this slide up. Maybe we'll have some questions come in. There may be some glitchy problem with the Q&A thing. But I have a question for you to start with. So early on in your presentation, you were talking about the possibility of a very frightening experience with psilocybin. And I'm wondering about study participants who are in the last stages of their lives and what can be done. You've talked about set and setting, you've talked about trained facilitators being present, you've talked about follow-up. Do all of these address that possibility sufficiently, or what would you say about how we navigate that problem?
Yeah, I mean, we could always do a better job than we've been doing, but I think all of these factors which we've discussed play a role in optimizing the conditions under which someone goes through this experience and lessens the likelihood of a bad trip. Establishing rapport ahead of time with the facilitator, going through preparatory sessions where you learn about the range of effects of the drug. And you're also told, very importantly, that if you hit a rough patch, it's important to keep in mind that this is you've taken a drug which has altered your sense of self. It may be creating some anxiety, but important to keep in mind that this is a time-limited reaction, and that if patient over a short period of time, you will return to your sense of accustomed self. You will become yourself again. One of the scariest parts of a bad trip would be this notion that you've lost touch with who you are and you will never become that person again. So I think it's, I went through this recently with a subject at UCLA. I was asked to sit in and kind of do a little teaching on how to administer the drug. And sure enough, the subject had a very frightening experience. He started to stand up, and I was concerned he might try to get out of the room. So I went into a wrap where I just basically told him that I understood he was quite anxious, and I could understand his distress, but very important for him to be aware that it will be, this anxiety is short-limited, this sense of being alienated from himself and the fearfulness of not recovering himself, those fears will be short-limited. He will get his sense of self will return. All he needed to do was sit down and be patient and just keep breathing. And within minutes, the guy had completely, his mood had reequilibrated. He was feeling fine. The anxiety dissipated, and he proceeded to have a very, very positive, the next several hour experience. So, we really have to optimize safety concerns. Also, very important when you're talking to someone about having a psychedelic experience, that they have an intention that is like a proper intention. It's an intention like geared towards healing, or geared towards insight, or geared towards having a powerful psycho-spiritual experience, that it not be for having a great time. That the intention of having a recreational experience, at least for some people, will put them at greater risk. It trivializes ahead of time the experience. It kind of can contribute to their not doing their due diligence in regards to being prepared or taking the preparation seriously. So, yeah.
Okay, so
Did I kind of answer that?
we have a related question, which is your thoughts on companies working on removing the psychoactive component of the entheogen and leaving the therapeutic component. So the idea that it's possible to create psychedelics without the visual component.
Well, actually, what some people are wondering is, do you need the psychotropic experience at all? Could you administer the drug to someone who's been anesthetized, and might they have on a purely biological basis and receptor alterations have a therapeutic experience? I'm very dubious about that. I think the psychological component and even the psychospiritual component are key to facilitating optimal outcome. So I know, spiritual experience, mystical experience, religious experience are controversial in our culture, but the data does seem to indicate an association, and we know from the anthropologic record that native peoples used it as part of their psychospiritual belief system. So there seems to be something intrinsic within these compounds, which under the optimally prepared condition will facilitate a powerful transpersonal or transcendent mystical level experience. And this has been, you can observe this in the anthropologic record, and you can, and this has been a replicable phenomena going back to the 1950s. Humphrey Osmond, when he treated alcoholics, noted that those individuals who during their what was often a one psychedelic experience had a powerful spiritual experience, they were the most likely to establish and maintain sobriety. This was the alcohol abuse patient population, that the ones who were most likely to get off of and stay off of alcohol were those who during the course of their many-hour session had a powerful mystico-mimetic experience.
And also, I think we'll take this as the last question. What type of psilocybin mushroom will you use for the study? Have you decided?
Oh, it's not mushrooms. What we use
Oh,
are synthesized in the laboratory. So so psilocybin was discovered in actual mushrooms, but in our country, the regulatory bodies are not comfortable with plant products because they contain generally a mix of different active compounds, a mix of different alkaloids. So the system more or less insists upon an isolated alkaloid, which is thought to be the most powerful component of the plant or the fungi, and in this case, psilocybin. So this is all laboratory synthesized material we use.
right. So a distinction is made that perhaps using these plant medicines for physical conditions could be accomplished in a form without psychoactive components.
Well, I mean, all of these possible models should be explored. You know, and psilocybin is not, or psilocybin mushrooms are not the only, you know, plant material out there which needs further exploration. I found the ayahuasca work we did in Brazil was fascinating, and there's never been an ayahuasca administration study in the U.S. for the reasons I mentioned. But I tell you, there's great opportunity for future investigators in this area. I mean, we've been basically for the last half century, we've been kind of treading water, just kind of keeping this model aloft and hoping it wouldn't die out altogether. And but now we're at the point where it's on the verge of significantly expanding. You know, more research centers, even capacity to administer these compounds legally in certain cities and states. So again, it's a rapidly changing picture, but again, if we approach this with the proper intention and optimize safety and ethical parameters, we stand a better chance to for this field to really establish itself in a healthy manner that will allow it to persist into the future.
Well, it's been very helpful to leave this future challenges slide up for us because it shows the extent of things that we have to do besides all of the things that we've just been talking about. So I'm very grateful, Dr. Grob. This has been such an inspiring and also informational presentation for us. Thank you very much.
Oh, sure. My pleasure.
Thanks. Okay, and thank you to those of you who participated, and we look forward to seeing you at our next event. Thank you all. Goodbye.